There's also one for the state of Texas. Let me pull this, and I like this one. There's a whole lot to play with on here, but one that's really helpful is you can toggle down here. It starts out on case data, but you can switch it to hospital data. And what I like to look at is hospitals statewide. And so this shows how many were hospitalized in the state of Texas day by day by day by day. And then it increased here in July, and then it's come back down. And it's looks like it may be starting to go back up a little bit. We'll just have to see what's going on there. But I think that's really helpful. You can break it down by regional as well. So it'll show you here, we're in trauma service area B. It shows how many beds we have available, how many are currently hospitalized in our whole region. So that takes into account some of the smaller hospitals. So it's hard to get exact info for the smaller areas, but in general, this will give you all the information that you need. This one is the Johns Hopkins one. I'm sure everybody's probably looked at this one by now. There's a global map, a US map. I just went ahead and went straight to daily cases. I brought this up, mostly somebody had a question on, where are we on the curve currently? I don't really know that we're kind of looking at that as much as we were before. I do think the curve was flattened pretty well. That's what all this was here. Unfortunately, this is when New York, New Jersey, the Northeast were kind of getting hammered. Then things settled down there a little bit, and then the rest of the country just took off from there. So we're coming back down a little bit. We'll have to see what's going to happen here, in the next few months. One of the questions was the most common transmission. I'm not exactly sure if that's talking about like droplet versus aerosol or what. But yeah, I mean, it's pretty much a droplet. There's some talk about whether or not it's airborne. It's not really we always talk about them as though they're just very distinct black and white. This is droplet, this is airborne. I mean, it's a spectrum of kind of droplet sizes down into aerosols. And so I don't know it's definitively known what they're at right now. I mean, reading on it, so the virus is around 0.1 microns, but then when someone coughs, they don't just expel the virus. It comes out in droplets or aerosols. So I think most likely it's ones that are around 1 micron to 10 microns are where people are getting infected. And so we'll talk about that a little bit more when we come back to masks. As far as most common transmission, like location, so family members seem to be the most common ones who secondarily get infected. So various studies look around 15 to 20% of family members of someone who are infected will get infected, which, why is it only 20%? I would kind of expect it to be higher, although 1 in 5 is still pretty high. They don't break it down necessarily into spouses, children, other people living in the home, roommates who may not even, really share any living spaces. It does seem like spouses or intimate partners are most likely to get infected, which is not surprising to anyone. You're kissing, you're sharing rooms, you're sleeping next to each other. Kids don't seem to get it as much. I mean, it's a little bit harder to know because I don't know that kids are tested quite as much because it's probably a little bit harder to get testing on them just because it's hard to have a kid have a nasopharyngeal swab. But even so, they do very well with it for the most part. Large indoor gatherings are a big place for people to get sick as well, especially in areas that are loud where people are having to talk louder or sing loudly. So unfortunately, there have been a lot of large events where people got, infected from like choirs or something like that. So really indoor gatherings, particularly where people are not wearing masks, seem to be a pretty big risk factor. I came across something the other day, or actually Nicole Hines had sent it to me on, we talk about the R naught or the basic reproduction number a lot, how many individuals will one sick person infect. Well, there's another number that they look at, and it's kind of an unusual coefficient, but it's basically showing that a large number of people infected come from a kind of small number of infected individuals. So this is what they're talking about with these super spreader events, where you may have an event where one person was sick and led to, 50, 60, 70% of people at that event getting positive, whereas you have another individual who's also very sick at an indoor gathering and almost nobody around them gets sick. Why? We don't know exactly. Maybe it just depends on what their viral load was at the time that they were at the event, how close they really were to these other individuals. We don't really know, but it seems to be some other little coefficient there that not everybody spreads it as efficiently to others. And right now we don't know how to predict who that is. It's, historically with the flu, it's things like children, older adults, those who are immunosuppressed or immunocompromised, they shed more virus and they shed longer. So it's probably something pretty similar for coronavirus as well. The spectrum of symptoms, that was one of the questions. So, I mean, it's pretty much anything you can think of at this point, since we have everywhere from asymptomatic individuals to those who are ending up with basically septic shock, multi-organ failure, and death. So, you know, it's really hard to predict. Most commonly are going to be cough, fever, shortness of breath. I mean, the fever deal is a little bit tricky. I remember there was one article that came out, I think it's a New England Journal, from a lot of these cases in New York when they were having their big surge, and only about a third of individuals had fever at the time of presentation to the hospital. Most of them at some point ended up having fever, but not everyone. And I will say more anecdotally from employee health standpoint, and from what I've heard other people in the community, particularly with younger individuals, fever is not all that common. So you need to watch out for other symptoms. There's a lot of stuff with upper respiratory, headaches, people saying they just kind of have this mental fog, you know, they can't concentrate very well. A lot of those kinds of things. GI symptoms for a while seem to be fairly common. I haven't heard of that quite as much lately, but you know, if you're having upper respiratory symptoms and then now you're having GI as well, some other things going on that may be concerning for a possible infection. What to do when exposed. So there is a self-attestation form on the HSC website. Actually, if you get these emails every day, they say something about announcements. If you go on there and go to the tab that says for employees, it'll lead you to the website where you can fill out the self-attestation. And so it'll ask you about, you know, were you exposed, any symptoms that you're currently having. It asks you all about where you work and that. But basically that goes to the employee health office. And then once you filled that out, they'll reach out to you and then they'll get more information on, okay, when exactly when you were exposed, who were you around? And this is also if you have a positive test, you need to fill out the self-attestation. You really should be letting employee health know anytime you get tested, even if you get tested elsewhere, just because we have to keep track of all of that. But that's the most important thing to do. I mean, if you get exposed, you know, right now, you don't need to panic and worry about, okay, am I already sick? I mean, the incubation period, yes, it says 2 to 14 days. The median seems to be around 5 to 7 days, which is why we ask individuals to wait about 5 to 7 days after any exposure before they get tested. And that's if they need to get tested. If it's a very low risk exposure and you're not having any symptoms at day 5 or 7, then there's probably not a lot of benefit in being tested. Now, a high risk exposure, even if you're asymptomatic, you may consider being tested in that time window. But the problem is the CDC still says if you have a high risk exposure today and you get tested at day 7 after the exposure and you're negative, that doesn't mean you won't go on to develop infection because of the very long and variable incubation period. So you need to follow what employee health tells you. I mean, we're trying to work with people and sometimes bringing people back, you know, sooner if it's absolutely necessary. You know, there's just no coverage available for a certain service line. Then sometimes we'll look into doing this testing earlier and maybe testing repeatedly. But that's really what to do kind of when you're exposed. Let me look here. So what's on the horizon for flu season? You know, most years around this time, there's a lot of talk going on from like CDC and other sources as to expectations for the flu season. I haven't heard quite as much this year. I don't know if they're, you know, so bogged down with COVID that they're not as doing many predictions with influenza. I mean, the concern obviously is if you have a bad flu season combined with COVID, then it may overwhelm the healthcare system. Flu season is generally our busiest season for the hospital, particularly for like the medical ICU and the general med-surg wards, just because you have people come in with obviously a respiratory infection. So we really want to try and avoid, you know, maxing out our ICUs. They've been pretty full for quite some time now, not just with COVID, but COVID's adding on to that. If you got 20, 30, 40 COVID patients in the ICU, that's that many beds you're taking away from traumas, cardiac arrest, burn patients, DKAs, all kinds of things. So one thing that will be interesting to see is the flu season impacted at all by having a high percentage of mask wearing? So that actually question came up a couple of times, and it's regarding evidence of masks in everyday life. So this one's pretty hard to answer. I don't know that there's any absolute study that shows whether masks work or not. I tried to look through and find a bunch. There was actually one that just came out on this kind of national ID listserv. It was in Nature, and they looked at a whole bunch of different studies involving mask use. And they've kind of come across the same thing that I have, that there's not one definitive study that shows that they absolutely work, but the majority of the studies have a trend towards benefit. Now, a lot of those studies are more looking at influenza and saying, okay, does having large number of people wearing masks decrease numbers of infections? Well, the issue they run into in most of these studies, and what we see, in the real world, is compliance. So there was a study where they enrolled individuals, so pediatric patients, so any children who came in who were flu positive, they asked the family members to wear masks. It was not done in the US, so they call them P2 masks or surgical masks. P2 mask is basically like an N95. And so, and then they asked some families to just do whatever they would do normally, which is generally not wear a mask. And so the compliance in that was well under 50%. At day one, it was like 60%, and then every day from there it fell off. But what was interesting, in the families that were compliant with the mask, they had very low rates of developing flu in that household. So it does seem from that study that there is some benefit. There's a couple of studies going on in Denmark right now. There's one they enrolled 6,000 patients, and I think they've actually completed it, but they don't have the data yet. And they split them in half and told half of them to wear surgical masks to work. And this is just any kind of work, not healthcare. And the other half to just do what they normally would. Again, most people aren't normally going to wear a mask. And so it'll be interesting to see what that shows. And then in another study in Denmark, they're trying to enroll 40,000 families, and they're going to give half of those households double layer cloth masks to see if those help. There have been lots of different studies now on whether or not cloth masks have any filtering efficacy. It's not excellent, although it depends on which kind of material you're going to use. Interestingly, tea towels are pretty good. They have a pretty tight knit weave. There's some looking at using various layers, so like 2 layers of a cotton with silk in between, or some sort of polyester. And I think the idea is that it also creates a little bit of static electricity in there, which may prevent the virus coming through. Now, what not many of the studies look at is actually having the wearer, the sick individual wearing the mask and seeing if it decreased spread. There's a few on there, and same deal, they also trend towards benefit. I think logically it would make sense that if a person who is sick is wearing a mask, even if it filters out 50% of what they're going to be coughing into the air, that should create less secondary infections. This is why we wear masks when we're in the OR and doing sterile procedures. Why would it not make sense for a person who's also sick? Now, that's not to say that you can just wear a mask when you're floridly ill and go to work and you're not going to get anybody else around you sick. But it may help for those people who are asymptomatic or pre-symptomatic. They're out grocery shopping or doing whatever they may need to be doing, and hopefully decreasing spread to individuals around them. The last point on masks is, okay, let's say it doesn't keep you from getting you sick, but it may decrease the inoculum size. And so the idea, and we see this with lots of different kinds of organisms, is that the lower the inoculum, the less sick that you get in the long run. Is there anything to absolutely back that up? No, but it's a pretty simple measure. I think I don't think it's hard for individuals to wear a mask, pretty frequently and be okay. I know there for a while they were talking about masks making people sick and your carbon dioxide levels go up and your oxygen levels go down. That's a bunch of nonsense. We have surgeons, we have dental hygienists, we have people who work in construction, all kinds of individuals who wear masks all day long at work, and I've never heard of them just dropping dead left and right. So I don't even know where that came from. Let's see. So when will a COVID vaccine be out? I don't really know. There was a webinar from I think it was DSHS that I need to go back and watch. I think it was last week. And they were talking about updates on flu, but talking to people who have listened to it, it's the same deal. They don't have any definitive dates set. I think they're pretty hopeful that by the end of the year, there will be a vaccine ready. Now, which one is it going to be? I don't know. There's several different ones in phase 3 trials right now, and they all use different technology. So, one of the ones that everybody's looking at is this Moderna vaccine, uses messenger RNA. Well, that's, to my knowledge, there's no current licensed vaccines that use mRNA. Now, I did have to read on it because since there aren't any that are currently manufactured that way, I had to go read on it. It's a method that's been around for almost 30 years. I think they developed it in the 90s. They've tried to do it in animal studies, and in animal studies, it seemed to work out. They've done some clinical studies on other viruses, HIV, rabies, Zika, there were several others. and they just don't seem to get as robust of a response in humans. And it seemed to be more from a delivery mechanism they've had issues with. Now, in the last several years, they've apparently discovered newer technologies, kind of using nanoparticles and lipid formulations that help deliver the vaccine. So it'll be interesting to see what they show. The second part of that question was, do I trust the vaccine? I trust the people making the vaccine. I think for a while, and like everything else with this, it was very politicized, and people were trying to rush it out. You know, if there was a vaccine that just came out, I don't know, immediately before the election, and it was only, you know, approved by non-medical individuals, then I don't know how much weight I would put on that. But I don't see one being ready by then. I think it's going through their normal course. People have been enrolled in these safety trials for quite some time now, and then they're enrolling more individuals for the phase 3 trials. And my understanding is they're going to wait 2 months past when the last individuals have gotten the vaccine before they try to make any analysis, just to look at that safety effect or safety aspect of it a little bit more. So I don't know. We'll have to see. It's hard to keep up with every single one that's on there. There's tons of vaccines in trials right now. So we'll just have to see. Once one comes out, I will try to review it to the best of my ability. I'm sure a lot of other people will be looking at it as well. I'm sure we'll have like Dr. Tarbox with immunology take a look and just see which ones we feel is going to be best for us. All right, another question. Has our reaction gone too far? This is talking about, you know, we see the worst of the worst in the hospital side, but, you know, in the community, what was the second? Oh, should government relax regulations? I think the government has already relaxed a lot of regulations. I mean, kids are back in school, bars are opening back up in a couple of days, although some of them have been open through these, you know, caveat of you can call yourself a restaurant if you give them a, you know, bag of chips, whenever they order their beer. So I think the government already has relaxed a lot of regulations. I don't know if someone had a specific regulation they were concerned about with that question, but I just think we need to be careful opening up a whole lot.
Yes, thank you.
Okay. But yeah, I mean, again, I don't know if there was a specific thing that someone was concerned about with that question, but I think a lot of stuff has already opened back up. Right before going into winter is probably not the best time to just go full blast and open everything, just because you're going to have the, you know, combination of flu, other respiratory illnesses, and coronavirus. So next question, where can I get an N95? So Jay, I believe y'all were able to get some N95s from Employee Health's office. So there should be some available there. The second part of the question was, you know, the KN95 doesn't fit everybody well, and it's also not FDA approved. So I agree, if you, an N95 would be the best thing to use if you're seeing COVID patients. You know, our fellow on ID, Dr. Gutal, he wears an N95 at all times, and that's okay. I don't think he's using a ton of them. He's reusing his, but we don't just want to burn through our supplies. We have a good supply right now. The issue with the N95s was, and I think still is that we're having trouble getting the duckbill masks, which seem to fit more people than the construction style masks. And then the other problem we run into is you can't just buy like 20 of one kind of mask. If you're going to order it, they want you to order like 5,000 at a time. Well, what if you get one and it doesn't fit anybody at all, and you just wasted, you know, $25,000 on masks? We've have run into that issue a couple of times, not quite that much money, but ordered large amount of masks, and then they ended up not really being all that useful. If you haven't been fit tested with a certain type of mask or an N95, you should be able to contact, I think it's TJ Smith. You may just contact the Employee Health Office, but they can do some number of fit testing. Now, they don't have unlimited supplies to do that either. So really needs to be for individuals who are going to be seeing COVID patients if y'all haven't already been fit tested. And then UMC should have N95s as well. Like if you're going into one of the COVID units, they should have some available for y'all. I haven't heard of them having issues, at least recently, being out of them.
So Jacob, I'll jump in real quick. And so guys, you know, we've sent out some emails, just reminders. And if there are PPE needs, I know right now we don't have any N95s in our office. We do have, you know, surgical masks, KN95s, face shields, those type of things for personal use. But if there's a need for the department, they can always work through us, so we can try to reach out to our various contacts, because we have heard that the Texas Medical Association is also providing out back to the county medical societies, which provided a donation in the past. And so again, if you have a need for one that you're not getting through your clinical resources, you can let us know so we can help try to facilitate. But at the moment, we don't have any N95s on hand, but we can probably get some.
Okay, that's good to know. And I need to talk to Nicole about that too, because she thought y'all still had some. All right, that's good. Common myths about COVID-19. I don't really know what, I don't know if this is going back to when, you know, people were calling it a hoax and all of that. It's obviously not a hoax. We already talked about it being very politicized, which is not really good for anything. It is not going to go away with the election. I cannot stand when I see people put that on Facebook or say it on the news. Yes, it's been politicized, but what they need to do is see these individuals who have been sick and are still sick, or have, you know, family members who've passed away from this. It's a very real illness. It affects people very differently. For some reason, we're seeing these, I don't know, they're calling them, quote, long haulers, individuals who get sick and, you know, they don't die. That's great. But now they're just having profound fatigue, weakness. There are people who have myocarditis, lasting lung damage. And these aren't all just elderly individuals. Some of them are fairly young, healthy people who just can't seem to kind of kick it. They're just not getting back to their normal selves. And how long is that going to last? We have no idea. I've seen reports of individuals who are essentially asymptomatic, that when they've done echoes or looked at troponins, even a few months later, there's still evidence of myocardial damage. And so what are the long-term effects of that? We don't know. So it's not just the number of people dying, even though that's higher than we want it to be. There's a lot of other effects that we have to keep in mind. Should we still have limitations on travel to U.S. destinations? So to my knowledge, I don't know if this is, do you mean like the HSC restricting travel? Is the person who wrote that question want to elaborate a little bit? To my knowledge, the HSC is not restricting travel anywhere in the U.S. We are still restricting international travel. Yes, the CDC took the words quarantine out, like required quarantine out of their travel recommendations or international travel, but it still says anybody who travels internationally should stay home as much as possible for 14 days. That's saying quarantine without using the word quarantine. So, you know, if there's somewhere that you absolutely have to go, we get there sometimes emergencies. We have a lot of residents, fellows who are originally from other countries, still have a lot of family in other countries. We will try to work with you as best we can, but remember, we're trying to protect you. We're trying to protect your fellow coworkers, and we're also trying to protect patients. You know, Jay talked about this at the very beginning. There are a lot more individuals who are sick right now, and then because of that, a lot more on quarantine. So we just have to keep that under wraps. I mean, if nobody's around to take care of the patients, then it's not going to end well. So, all right. So those were all the questions I had that were sent to me ahead of time. I got maybe some of the travel destinations you're talking about. Like, I guess if you were to go to New Mexico right now, they want you to have a test before you go within 72 hours. We have no control over that. That's state choices. That's not, you know, Texas government. That's not federal government. That's each individual state's decision. So it's a little bit weird to me. New Mexico's always got this, I don't know. It just bothers me a little bit that they send all their sick individuals as transfers to our hospitals and then tell us that we can't travel over there. But, you know, that's a completely different issue. So what other questions do y'all have for me?
Dr. Nichols, I have a question, please.
Uh-huh.
Is there any expiration for the mask? I'm wearing my mask for like 2 weeks right now.
Uh-huh.
I'm not sure what's the right thing to do when I should exchange my mask.
You just mean like a surgical mask?
I'm wearing like the N95, the green ones that were given by the department.
So are y'all still doing the decontamination?
So that my question. When we should do that decontamination? Every how many days?
I mean, there's no science behind doing it. When they were doing it once a week, I think it was a good idea to decontaminate it every week. Are you wearing this in the COVID units, or is this just one you're just wearing around?
Wearing around actually.
Then I don't really know how often it needs to be decontaminated. I mean, if you're not coming across anybody who has COVID that you know of, I don't know that you have to send it off for decontamination. And changing it out, every week, every other week, or getting it decontaminated at that time is probably reasonable. Um, but that one's been hard from the beginning. There's nothing to guide doing it. There's data saying, yeah, the vaporized hydrogen peroxide works. It cleans the mask, but there's no guidance on how often we should be doing it. And I think the group that does it has backed off to only doing it like once every other week or once a month now. So we may have to look
And
at.
data about surgical masks.
Yeah, with the surgical mask, I mean, we have plenty of those, and I don't think getting those are an issue. So wear it for a week or 2 weeks, really until the straps aren't working really well on it. I usually wear mine for a couple of weeks at a time and then dispose of it and get a new one. I'm not trying to decontaminate those. I think we have a good enough supply that we don't need to worry about it.
Okay, thank you very much.
You're welcome. Anybody else?
Touching base on how political the issue got, and I know it's here. Here, it's not so much of a discussion, but back home, people are still bringing this up. And back home is in Brazil about hydroxychloroquine and potential use of it before people get really sick. So, has it already been completely ruled out?
Yeah, I think so. There was another article that came out last week. I think it was in the UK. I need to go and look at the actual numbers, but the synopsis was it didn't work and they may have had increased mortality in the hydroxychloroquine group. Now, you have to take that with a grain of salt because the U.S. Department of Veterans Affairs uh, did the same thing several months ago, and they said hydroxychloroquine had increased mortality. Well, yeah, they were only using it in critically ill individuals. You could give anything to critically ill individuals, and your mortality is going to be higher. Giving it early, if that was going to work, would probably be the best time to give it. But I mean, there's studies now where it didn't work in people who had mild to moderate illness. They've tried to use it for post-exposure prophylaxis, and it didn't work. People still got sick at the same rates as those that weren't on it. So I just, yes, it was very politicized. I was actually someone who thought, hey, there may be something to it, looking at the French study and Didier Rault's information. Yeah, it was only on 7 patients, but you're like, man, almost essentially all of them had negative PCR after 7 days, whereas only like, I think 15% or something in the other group did. But when you go and look at their actual data, they excluded like 4 people, 2 of them who got transferred to the ICU, 1 who died, and 1 who left AMA. Well, good grief. You can't just do that in a study and say it was okay.
Mhm.
Yes. Okay, so
Yeah,
question.
I have one question.
Hold on, John.
Um,
1 second. There's someone
Sure.
in the chat. So if we had an
Sure.
exposure, do we need to report it if we did not develop symptoms and it was a low risk exposure? I mean, if this is like, hey, I heard my co-resident developed COVID and I was around them 4 days ago, no, that's probably not one that needs to be reported. But anytime you're concerned that you had a high risk exposure, go ahead and report it. And the worst thing they're going to tell you is nothing needs to be done. Thanks for letting us know. Most of the contact tracing is really going to be from when there is a positive individual. They're going to ask that individual who all they've been around. Were they wearing masks? Were they not wearing masks? Which, by the way, y'all should all be wearing masks at all times. I get it. It's hard. I know the internal medicine residents probably got sick of me popping up in the resident room and telling them to wear masks, particularly early on. But my concern was it was going to take one individual who was going to be positive, and A, they may get others sick, and B, even if they're not sick, that would be a high risk exposure if everybody's sitting around with no masks. So we're back to that situation where we have a whole lot of people on quarantine, and then you're depending on your other residents to pick up the slack. Eating is a difficult one. I mean, it's easy for me to say I've got my own office that I can sit in and eat. Y'all have the resident room and other areas. But honestly, I don't really sit in my office very much and eat. I go outside a lot of times and get some fresh air and eat. So I think anytime you can be outdoors, especially with your mask off, is probably a safer bet. Now, I'm not telling y'all that 20 people go sit at one of those little 5-person tables outside the pavilion there, but try to eat on your own as much as you can. Really, you just need to look at it as, if I were to test positive tomorrow, who was I around today that I could have potentially exposed? That needs to be sort of in the back of your mind at all times, okay? I'm not trying to harp on y'all. I just know we've seen several situations within the HSC. We've had quite a few positive employees, residents, students, and almost every secondary infection from that positive person were from those they were eating lunch with, almost all of them. So, all right, John.
Yeah, if a patient is tested positive for COVID and home oxygen saturation is around 90%, would they still, like 94%, would they still get that dexamethasone and everything at home, or just stay at home if their symptoms is not so severe?
That's a pretty good question, and I think a lot of that comes down to who their PCP is. I know Dr. Little for a while was prescribing, I think like azithromycin for some of his patients, and also doing nebulized Pulmicort, and there were some other physicians doing that. I don't know what the data is right now on patients with kind of these mild to moderate infections. I'll have to look at that some more. Most of the treatment that's been done in the hospital has really been done by our Pulm Crit guys, and then the hospitalists, and really the medicine and family medicine residents. The ID team, we've been consulted on some of them, but we're not following all of these individuals. We tried to decide early on if we should be or not, but it would be we're a pretty small division, and we weren't sure we'd be able to handle the load of, right now there's 50 plus patients in the hospital with COVID, and that's just not something that we think we can manage. So we're available for questions, but I don't know that there's a whole lot of data on specifically what to do for those who are at home. I think I would probably kind of look at their risk factors. If they seem like there's someone who's high risk, I might consider giving them something like dexamethasone or maybe prednisone. I don't know that it has to be dexamethasone. That's what everything's been with. But maybe looking at giving them a course of prednisone or methylprednisolone or something. So there's another in the chat. How long will a COVID positive person be infectious after symptoms subside? They're still COVID positive after 1 month, but have subsided. Are they still infectious? So the CDC put out some information on this quite a while back. Initially they were wanting everybody to have 2 negative tests, and then it transitioned to, okay, for those who can't get tests, then let's do a time-based strategy. And they were actually doing 7 days from when a person's symptoms developed, or 7 days from their test to clear them. Now they've moved that to 10 days. So if you have mild to moderate disease, then it's 10 days from when your symptoms developed, or 10 days from when you tested positive, actually whichever is earlier. And then as long as you're afebrile for 24 hours without the use of medications and your symptoms are improving, they don't say resolved, they just say improving, then an individual can be cleared. Again, that's for mild and moderate. For severe or critically ill or patients who are immunosuppressed, it's 20 days, but with the rest of the same disclaimers, afebrile, symptoms improving, so on and so forth. So really for your people in the hospital, most of them are probably going to be the 20 days because that's why they're in the hospital. They're needing oxygen or some other sort of support. What I thought was interesting, their cutoff for O2 sats was actually under 94%. So that may actually be people who aren't quite requiring oxygen. And then they would still suggest that those individuals be on isolation for 20 days. Yes, the testing will be positive. It can be for months. I heard a report from someone the other day that basically they're doing this kind of surveillance testing in I think it's a nursing home that had several positive individuals, and they're just testing them weekly. And they're about 180 days out for some of these people, and they're still testing positive by PCR. So that's why we moved away from PCR pretty early on. We're doing antigen testing now, at least for the HSC, and that looks for the nucleocapsid, which, I mean, logically should only be present with a viable virus, or at least one that was very, very recently viable. So, because I mean, that's the intact virus. So, but yeah, if they're 1 month out and they're not having any symptoms, but they're still testing positive, I don't think there's any way that person's still infectious. there's been several studies. Sorry, I guess I should have mentioned that earlier. So where they came up with the 10 days is there are a lot of studies. They're not huge studies, but now there's multiple of them where they try to culture the virus from infected individuals from the day that their symptoms started or from whenever they tested positive. And to my knowledge, nobody has been culture positive more than 10 days out from when their symptoms started, except for those who were critically ill or immunosuppressed or immunocompromised. So that's where the 10-day cutoff comes from. The 20-day cutoff comes from even those individuals who culture positive longer than 10 days, it was like 95% or more were culture negative by day 15. So they extrapolated that out to 20 days. So. Those are good questions. Anybody else? So yeah, if y'all ever have concerns, I mean, I think Jay touched on it earlier about PPE or something that is needed for y'all feel like something that's not getting done, GME is there to help y'all with that, okay? They want to take care of y'all, make sure y'all are healthy, able to do the jobs that you need to do. So you can always reach out to them. If you're more worried about exposures or not sure what to do in a certain situation, that's what employee health is for. So that's Diane Baker and Nicole Hines and them. I mean, they are working a lot. I think they're doing a lot more than most people realize. I would probably have no idea how much they did, except now that I work with them. They truly care about y'all's health. I mean, they are working crazy hours. They're on all the time to try and help out. So.
All right. Well, thank you, Dr. Nichols. Again, guys, if you have questions that come up in the future, you can always use us to pass it on and to get the answers that you may need. And just look out for other emails that will be coming out regarding access to PPE and other resources for you. So thank you all for coming today. Thank you, Dr. Nichols, and we'll talk soon.
All right. Thanks, everybody. And if y'all have an email or a question that y'all didn't want to ask on here, feel free to email me. It's just jacob.nichols@ttuhsc.edu. Thanks, guys.